Good afternoon, and I am going to be your moderator today. My name is David Wheeler, and I'm the Clinical Associate Professor for Director of Clinical Education at Jacksonville University, the Master's of Science in Respiratory Care. Just a reminder, this webcast and any accompanying materials are copyrighted by the American Association of Respiratory Care. Any public display, sale, copy, or distribution of the video or materials can only be undertaken with prior written consent of the AARC. My name is David Wheeler, as I've said, and we would like to welcome you to today's program, The Impact of Breathing Pattern and Nebulization on Expelled Viral Content During Mechanical Ventilation using an ex vivo porcine lung system. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, discuss the implications of the study on patient care. I am pleased to welcome Dr. Denise Willis, Dr. Denise Willis is a research respiratory therapist for respiratory care services at Arkansas Children's Hospital. She's been in this role since 2018 and previously spent 16 years in the outpatient pulmonary clinic working with technology-dependent children. Denise has over 26 years of experience. She's a wonderful, wonderful person, great clinician, and she's also the section editor for respiratory care. Ms. Willis discloses a relationship with the Dahlias, and I have no relationships. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of the specific product, but to merely illustrate the point of emphasis and to provide information and education. Denise, a very big welcome to the program.
Thank you, and hello and happy Friday to everyone. I will have to say, though, I am not a doctor, so we'll have to excuse that part. But thank you all for joining in, and thank you for joining today's JournalCast for the Editor's Choice paper by Ring and colleagues. And this paper is relevant and timely due to the concerns of exposure to aerosols that were brought on by the pandemic. The aim of the study was to evaluate the effect of delivering nebulized medication on exhaled viral content during mechanical ventilation. Long before the COVID-19 pandemic, there were concerns about healthcare worker exposure to various types of aerosols. And aerosols are present in different forms. They can be produced from aerosol-generating procedures, and this is provoked from coughing, such as suctioning or airway clearance therapy. Occupational exposure to aerosolized medications is also a concern. Exposure to inhaled antibiotics such as amikacin, colistin, tobramycin, all of these are known to cause respiratory irritation and asthma-like symptoms. And also, nebulized pentamidine and ribavirin, they can have adverse effects, and that's why we have special precautions in place for administering those drugs. I'm sure many of us have probably inadvertently inhaled various medications intended for the patient at one time or another. I know in the past, I've probably had my fair share of albuterol, along with some upset toddlers who were not a fan of keeping their mask on during their nebulizer treatments. But these days, we're a lot more proactive about precautions for occupational exposure as compared to 25 years ago. Patient-generated aerosols from cough or sneeze are also of concern because they may contain bacteria or viral particles that could pass along infection. And these are cough and sneeze particles in general that may not even be associated with an aerosol-generating procedure. When the COVID-19 pandemic first began, there were a lot of changes made to our respiratory procedures. There were major concerns that nebulization would increase the risk of becoming infected, so other inhalers such as metered dose inhalers, soft mist inhalers, dry powder inhalers, those were all preferred over nebulizer therapy. And this ended up leading to a shortage of some inhalers such as albuterol, and this had a negative impact on individuals with chronic lung disease such as COPD and asthma. And then another issue with that is that not all inhaled medications are available in inhaler form and may only be available as a nebulizer solution. For example, take Dornase alpha. That's a common treatment for cystic fibrosis, but it's not available as an inhaler, only as a nebulizer solution. But you have to think about too, even when you do have multiple formulations available, you have to consider age and ability. And for example, dry powder inhalers, they require a specific technique, and patients need to be able to demonstrate and understand how to coordinate that technique. So that's not a good option for a young child or someone with severe neuromuscular weakness. And aerosols are generated from basically everything we do, from coughing and sneezing to even just talking and breathing. Large droplets are produced from coughing and talking, and these usually settle almost immediately. Particles that are 100 micrometers in size take about 10 seconds to settle. Intermediate sized droplets take a little longer, up to several minutes. Particles sized around 10 micrometers are estimated to take about 17 minutes to fall to the ground. And small particles are those less than 10 micrometers in diameter, and they can travel further and stay airborne for hours. And then droplet nuclei are less than 5 micrometers, and they are formed from evaporated liquid droplets. They can come from coughing, sneezing, singing, talking loudly, and any similar activity of that nature. Droplets that are 5 or more micrometers in size, they can deposit in the upper airway, whereas those less than 5 can potentially be inhaled in the lower respiratory tract. And this is referred to as the respirable range. And this is an important consideration for viral transmission through droplets. There was a study that evaluated aerosol samples for airborne influenza in the emergency department, and they found that 53% of the virus particles analyzed were in the respirable range. Now, these samples were not from individuals, but rather from the environment in the ED, and these samples were taken from different areas such as the waiting room, the triage area, and exam rooms. And there are a lot of factors that can influence the viability and infectivity of viral particles, but this was still a very interesting evaluation of airborne influenza, and that was published back in 2009. I think it's also important to understand the differences between aerosol generating and aerosol dispersion and how that relates to this study that we're going to be reviewing today. Aerosol generating procedures are those that promote aerosols through cough or stimulation, such as suctioning, intubation, or bronchoscopy. And the aerosols produced from these procedures, they could contain infectious bioaerosols that cause infection in healthcare workers. In contrast, aerosol dispersing procedures increase the distribution of exhaled aerosols and can carry particles further distances. Earlier in the pandemic, non-invasive ventilation and high-flow nasal cannula were classified as aerosol generating, and this led to aggressive intubation at that time. But non-invasive ventilation and high-flow nasal cannula do not generate additional bioaerosols through cough stimulation, so they are actually aerosol dispersing procedures rather than aerosol generating. And there are a lot of factors that come into play for dispersion, and the risk of transmission depends on the viral load, the size of the particles, how fast and how far they travel, and the duration of exposure. Coughing has been estimated to produce up to 3,000 droplets, and the distance traveled depends on the forcefulness of the cough, and we know not all coughs are the same, but the particle sizes that are within that cough, they're going to vary, as some will be large droplets that don't travel very far. Those are going to settle fairly quickly. And then it's also going to contain some of those smaller particles that could be suspended sometime in the air before they dissipate. And those smaller droplet nuclei, they can be transported by airflow and carried further away from that individual who is coughing. The transmission risk is considered higher for aerosol generating procedures as compared to aerosol dispersion, but you have to remember that during those dispersion procedures, the patient could cough at any time, and that's going to disperse those bioaerosols throughout the room. So it's important to use those mitigation strategies with all those procedures, and the appropriate PPE should be utilized during both types. This is a great illustration to help demonstrate the differences between aerosol generating and aerosol dispersion procedures. Figure A shows aerosol generated from normal breathing. So you have a small amount of aerosols that are produced, and they're going to travel a short distance before evaporating. In Figure B, you have a burst of aerosols generated from cough stimulation, and this can occur whether from suctioning, intubation, bronchoscopy, any procedure of that nature that's going to induce a cough. In this picture, it looks like this individual is being deep nasal suctioned, and that is sure to induce a cough. And in Figure C, here a nebulizer treatment is being administered, and that can cause aerosols to be dispersed further away. And the same is true for non-invasive ventilation or any type of oxygen therapy. These procedures are not generating bioaerosols, but their use can disperse aerosols further away from the patient. And there are some factors that can increase dispersion. For example, during treatment with high-flow nasal cannula, if the cannula becomes loose, or during non-invasive ventilation, the mask becomes displaced, or you have a large leak, the distance of aerosol dispersed could be increased. And then one other important concept to discuss before moving on to the details of the current study is to distinguish the difference in the different types of aerosols produced during nebulization. Medical aerosols are those produced from the device itself used to deliver the medication. And these aerosols should not contain infectious particles unless the medication solution or the nebulizer equipment is contaminated. Medical aerosols either deposit in the airways or are exhaled. Part of the medication aerosols will be inhaled and deposited into the patient's lungs, but a lot of it is exhaled into the environment, and those are considered to be fugitive aerosols. And different types of nebulizers and the method of delivery or the interface used, that can have an impact on the amount of fugitive aerosols generated and dispersed. Small volume nebulizers used with the mask have been found to produce more fugitive aerosols as compared to a mouthpiece. And small volume nebulizers generate higher concentrations of fugitive aerosols than vibrating mesh nebulizers. But when a vibrating mesh nebulizer is placed in line with a high flow cannula, it generates less fugitive aerosols than a vibrating mesh with a mouthpiece. So a lot of factors go into play for that can influence the amount of fugitive aerosols. Then we have bioaerosols, and these aerosols contain microorganisms that are exhaled from infected individuals. They could also be potentially generated from contaminated equipment. And these bioaerosols are what can increase the risk of transmitting infection. The aim of the study by Ring and colleagues was to evaluate the effect of nebulization and the impact of different breathing patterns on the amount of exhaled viral particles during invasive mechanical ventilation. The authors hypothesized that breathing patterns associated with more shear stress and turbulent flow, such as those coughing or sneezing, that those would produce more exhaled viral content as compared to tidal breathing. And the study did receive funding to support the research. The overall objective of the study was to determine the impact of aerosolized medications on the presence of viral content during mechanical ventilation. An ex vivo porcine lung model was used, and 4 different breathing patterns were evaluated that included tidal breathing, respiratory distress, coughing, and sneezing. Phase 1 served as the control and evaluated viral content during mechanical ventilation without the nebulizer, and then Phase 2 included the addition of the nebulizer. The study utilized 8 porcine lungs that were sourced from a retail processing facility, and these lungs were extracted from pigs that were raised for meat production. So these were not animals raised specifically for research purposes, but rather their lungs were repurposed for research once they were processed for meat production. The lungs were taken from 6-month-old Yorkshire hybrid pigs that weighed 118 kilograms. The lungs included the pleural membrane, the trachea, and the larynx. And porcine lungs have been commonly used for respiratory-related studies because there are some similarities in size and anatomy. Porcine lungs have similar anatomy to human lungs. In this picture here on the right, you can see the trachea, the carina, and the branching for the left and the right lungs. And the number of lobes for each lung is different from humans, but there's still a similar lobar structure. And in comparison, if you consider rodent lungs, they're quite a bit smaller than human lungs, and they don't have any lobe divisions on the left side. Porcine lungs also have a tracheobronchial tree with branching to smaller airways, and you can see that in this illustration in the picture on the left. They also have a similar histological composition in the respiratory tract, and for this reason, ex vivo lungs have been used as a surrogate in other studies to assess respiratory infections from various pathogens. And all of these similarities to human lungs help make porcine lungs a good model for translational respiratory research. This picture is from the paper, and it shows the setup for the study and a set of the actual lungs that were used. The lungs were placed in the supine position on a support ramp and elevated 30 degrees. They were intubated with a size 7.5 millimeter endotracheal tube, and then they were tested for air leaks using an inflation protocol. Each set of lungs were ventilated for 10 minutes with an inspiratory pressure of 20, PEEP of 20, and 15 breaths per minute. Air leaks were identified by a difference of more than 100 milliliters between the inhaled and exhaled tidal volume, and if that was identified, they were repaired with a fixation agent. After the inflation protocol was completed, 90 milliliters of bacteriophage stock was instilled through the endotracheal tube to introduce the viral content. I wanted to give just a little bit of background about bacteriophage. So bacteriophages, they're viruses that infect bacteria, and MS2 is produced in E. coli, and it can replicate fairly quickly. Bacteriophage MS2 has been used extensively as a surrogate for human viruses to study the spread of gastrointestinal and respiratory pathogens. It also has applications for studying targeted drug delivery and for water testing. MS2 is non-pathogenic to humans, and it's been used in several studies to evaluate the transfer of viral particles during handshake, and also for doffing PPE and reusing N95 masks. So it's been used quite a bit in various studies for evaluating viral particles. And the MS2 used in this study was prepared based on established protocols. And as stated earlier, there were 4 different breathing patterns evaluated, and each pattern was applied for 10 minutes. The ventilator was set to deliver volume ventilation with a tidal volume of 500 milliliters, and the PEEP was set on 5. All of this was with using heated humidification. And for tidal breathing, the rate was set on 15 breaths per minute, and for respiratory distress, it was 30 breaths. For cough and sneeze, there were a series of tidal breaths given, followed by extrapulmonary pressure to produce expiratory flows of 90 to 800 liters per minute at the end of inspiration. And this was provided manually while observing the expiratory flow rates. The expiratory phase was 0.5 seconds for cough and 0.7 seconds for sneeze. And this pattern was repeated 5 times within that 10-minute ventilation cycle for each of those patterns. And then each breathing pattern was completed both with and without the nebulizer to evaluate the impact of nebulization, with phase 1 being without nebulization and phase 2 introduced the nebulizer. A breath-enhanced nebulizer was modified and placed in line with the ventilator circuit for the nebulization phase of the study. Now, the paper does not specify exactly how the nebulizer was modified, but I suspect it was altered to make the nebulizer function without the breath enhancement. The nebulizer was connected to a T-piece adapter that was attached to the endotracheal tube, and then the ventilator circuit was connected to the top of the T-piece. And then 2.5 milligrams of albuterol was used to deliver the nebulization treatment. A polypropylene bacterial and viral filter was used to collect exhaled viral particles, and this was placed between the endotracheal tube and the ventilator circuit Y-piece. So the picture on the left shows the setup for phase 1, and then on the right you have the placement of the filter in phase 2 with the addition of the nebulizer. The filter was collected after each 10-minute breathing session, and the viral particles were then extracted from the filter and tested using quantitative PCR testing, or polymerase chain reaction. And this was to test for virus detection and measurement of the number of particles. PCR testing was repeated for 3 times for each filter, and that was performed based on established protocols. For each breathing pattern, both with and without the nebulizer, a new set of lungs, a new ventilator circuit, and a new nebulizer were used each time to help mitigate any potential compounding factors that might influence the results. So there were 8 total different scenarios, and each one used new lungs and new equipment. For the statistical analysis, the authors used factorial ANOVA to examine the effects of the nebulizer and the breathing pattern. And this is also called a two-way ANOVA, and the purpose of this type of analysis is to explore the influence of 2 or more independent variables on a single dependent variable. And in this case, the dependent variable is the viral content, and the independent variables are with and without the nebulizer and the different breathing patterns. Pairwise comparisons were done to evaluate the interactions between the individual variables, and they were reported with a 95% confidence interval, and the p-values were adjusted. So this type of adjustment, this is done when there are multiple pairwise tests on a single set of data to prevent the data from incorrectly appearing to be statistically significant or a type 1 error. And then all p-values were for two-tailed tests. The interaction effect on measured viral quantity between nebulization and breathing pattern was not statistically significant, as you can tell by this large p-value of 0.8. And then the partial eta squared value, that's that N2, that tells us about effect size of the different variables in ANOVA, and values for this range from 0 to 1, with larger values indicating a greater effect explained by the other variables, and 0 indicates that there was no effect. So the effect between nebulization and breathing pattern on viral content was a medium effect. There were no significant effects on viral content for breathing pattern, with a p-value of 0.26, and that had a large effect size. And then the addition of the nebulizer was also not significant, with a p-value of 0.98, and that effect size indicated no effect. Unweighted means of viral concentration counts were reported for each breathing pattern and with and without the nebulizer. So using unweighted measures, that controls for the effect of other variables, whereas weighted means would ignore the effects of the other variables. So tidal breathing was found to produce 121,000 nanograms per microliter, and this was similar to respiratory distress that was 130,000. Coughing produced 310,000, and then sneezing 160,000. And then with and without the nebulizer was similar at 180,000 nanograms. This figure represents the pairwise comparisons, and the white bars are the measurements for the control without the nebulizer, and the shaded bars are the viral counts with the nebulizer. And the different breathing patterns are identified on the x-axis with the corresponding measured viral quantity on the y-axis. And although coughing overall produced a larger amount of viral content than the other breathing patterns, there were no statistically significant mean differences found in the measured viral quantity compared to all breathing patterns. Tidal breathing with the nebulizer and respiratory distress without the nebulizer were the breathing patterns with the lowest amount of exhaled viral particles captured at the filter. And you'll notice here that not all of the boxes have the error bars for standard error. Only these here circled in red have error bars. And remember back in the methods, where it was stated that the viral samples that were collected from the filter, they were tested with PCR 3 times. So those samples that only included one valid PCR result did not have standard error. This table provides the mean and standard deviation for viral quantity for each individual breathing pattern, and then with and without the nebulizer, and then the total viral content for each pattern and with and without the nebulizer. And this is just looking at the data differently with descriptive statistics as opposed to the pairwise comparisons in the previous figure. This last column is the number of PCR measurements that were reported for each scenario, but since not all samples produce 3 valid results, there's not a standard deviation when only one measurement was available, and this is represented by the asterisk in that standard deviation column. And looking at the means, you see that overall, coughing still produced the largest amount of viral content, but again, that was found not to be statistically significant. The research by Ring and colleagues demonstrated that nebulization within the ventilator circuit during mechanical ventilation did not increase the viral content in an ex vivo porcine lung model. This compares to results from other studies that evaluated dispersion. A study that evaluated viral dispersion from invasive and non-invasive respiratory devices in a simulated ICU room found that mechanical ventilation with an endotracheal tube had lower amounts of viral dispersion compared to non-invasive devices, including helmet ventilation, bilevel ventilation with a face mask, non-rebreather mask, and both high and low flow oxygen. That study also used bacteriophage to infect the airway model, and then air samples were collected at different locations within the room and analyzed. Now, the focus of that study was different, though, since it evaluated dispersion in an ICU room, and that's different than evaluating viral content within the ventilator circuit. There was a study that evaluated aerosol dispersion from a high-flow nasal cannula in conventional oxygen therapy in adults, and that study found that high-flow nasal cannula was not associated with increased aerosols. However, when nebulization was used with high-flow nasal cannula, the number of particles were increased. The author's hypothesis that breathing patterns with greater shear stress and turbulent flow would produce more exhaled viral content was correct, even though there were no statistically significant differences compared to the other breathing patterns. And when you think about the cough mechanism, it's not surprising that coughing generated more viral content than tidal breathing. And the amount and size of droplets produced, it varies with different breathing patterns, and that can have an influence on the presence of viral particles. Nebulization is thought to increase the dispersion of aerosols in the environment, and this led to the recommendations to use inhalers instead of nebulizers early in the pandemic. But regardless of the delivery device used to administer inhaled medications, there's always a risk of cough that could generate infectious bioaerosols. And changing from a nebulizer to an inhaler does not change that risk, does not decrease the risk of cough. And a better understanding of that early on may have prevented some of the shortages that occurred with some inhalers. While the findings from the study demonstrated that nebulization during mechanical ventilation did not increase exhaled viral content, there are still some limitations to discuss, and all studies have limitations that need to be taken into account when interpreting the results and forming conclusions. Although porcine lungs have many similarities to human lungs, there are still differences that have to be considered when extrapolating those results to humans. And really using any type of lung model, that's always a limitation compared to in vivo studies, but not all studies might be ethical to do in vivo. We don't want to infect people with viral particles, so it would be very hard to do something like this in humans. The authors noted as one of their limitations that infectivity of the exhaled viral content was not evaluated. Only the amount of viral particles were measured. And this study evaluated aerosolized viral particles within the ventilator circuit and did not measure fugitive aerosols within the room that could contain infected bioaerosols. And also, we don't know what the impact of a leak within the system might have if the circuit becomes disconnected. And it's not a matter of if, it's when, because we know that happens in an ICU setting. The circuit is going to become disconnected at some point, and you would anticipate that those bioaerosols would be dispersed in the room. We also don't know how the results might be different if there was a leak around the endotracheal tube itself. And that can have an impact on the amount of viral content recovered within the circuit. And this study used a dual limb circuit, but there are some systems that use a single limb, so that would also need to be considered. And thinking about the impact that a leak within the system might have, one of the abstracts from my team that is going to be presented in the open forum next month at conference, it evaluated fugitive aerosols during mechanical ventilation with inline interpulmonary percussive ventilation, and we found that the adapter setting used to administer the inline IPV had an effect on the amount of fugitive aerosols because that adapter is adjustable to compensate for pressure relief depending on the mode that you're using. And then another limitation is that each scenario with the different breathing patterns with and without the nebulizer were only completed once. And repeating the same scenario a couple of times can show if those results are reproducible. Of course, with this study design that was used, that may have not been feasible because you would have had to have double or triple the amount of lungs available with using a new set of lungs each time. But using fresh lungs and new equipment for each trial is one of the strengths of this study. If the ventilator circuit had been reused, some of that viral content may have settled in the circuit and then possibly exhaled with the next breathing pattern. And then no discussion is complete without a statement about future research. More research is needed to expand this study and evaluate other factors such as fugitive aerosols, and because those fugitive aerosols could contain infectious bioaerosols, and also how different types of ventilator circuits and nebulizers and interfaces may have an effect on exhaled aerosols. The accompanying editorial by Saunders and Davis highlighted that the results are only applicable to patients ventilated with an endotracheal tube. Viral content was only evaluated within the ventilator circuit and not dispersion within the room. The study also did not address viral content in the upper airway and how that might contribute to exhaled aerosols, or how cough could be induced from aerosolized medications passing through the upper airway versus an endotracheal tube, and how cough without an artificial airway might influence dispersion of viral particles. The authors of the editorial also noted that additional study is needed in spontaneously breathing models that are open to the environment to assess the impact of fugitive aerosols, as well as the role of the upper airway on exhaled viral content. And the editorial concludes that the results suggest that nebulization within the ventilator circuit is not a biohazard risk. In conclusion, this study found that nebulization during mechanical ventilation did not increase exhaled viral content in a porcine lung model, and there were no significant differences in the amount of recovered viral content with different breathing patterns. Although there's still more work to be done to further evaluate the impact of nebulization during mechanical ventilation, this work by Ring and colleagues provides a foundation for future research on this topic. Thank you for your time, and that concludes the presentation portion of the session, and we will open it up for questions.
It was a wonderful, wonderful presentation, Professor. There is one question. It's from Arthur Truxton, and he asks if there were a difference. I don't believe it was part of the study, but you can correctly answer the question, with the addition of filters or expiratory filter.
So the question is, were there any changes of dispersal if there were two filters? So there was just one filter used for each breathing trial. Now I will say, let me go back to this picture here because I think I maybe know what you were referring to. One of the pictures, it appears that there is another filter. Yeah, so if you look here, where that red arrow is where the filter was placed. But if you look between the T-piece and the endotracheal tube, you see some material there. And I actually reached out to the author to ask him about that because I was thinking there were possibly two filters as well. But he said that was just some cotton material to prevent the bacteriophage, once they instilled it, from entering the system, and it was removed before the breathing trial started. Does that answer the question about two filters?
I think it does. I think it does as far as I'm concerned. What do you, now you've studied this paper extensively, what would you add as far as a takeaway for the bedside clinician? How can they clinically apply this research?
Yes, great question. Compared to some of the other studies that showed that mechanical ventilation produced lower aerosol dispersion compared to other things, you would assume that adding the nebulizer, because it did not increase the viral content, that perhaps the fugitive aerosol dispersion within the room may not be as much compared to other procedures such as high-flow nasal cannula. But that is that's where we need the next steps of this study to actually evaluate the dispersion within the room. But this is a great foundation for that, since we learned that there was no increased viral content within the circuit itself.
Excellent. And I'm sure that in your clinical practice, you handle lung transplant patients, you handle obviously cystic fibrosis patients who have a lot of medications that we have to deliver. Is there any advice you could give to people that maybe don't have the volume quite that you would, and from your clinical experience, based on obviously the concerns that this paper highlights, what would you advise the bedside therapist?
Well, I think with any type of aerosol, we just have to be vigilant about wearing appropriate PPE. And that's probably not going to change anytime soon from all the changes that we had to make with the pandemic, and just making sure you're protecting yourself. And I'm sure others have encountered this too. Perhaps a patient was admitted and you're giving therapy, but then later they test positive. Well, if you were doing all the appropriate PPE on the front end, your risk of exposure was definitely decreased.
Yes, that's very true and very wise. We still, I'm sure you would advise people to remain vigilant. Even though the numbers are down, we have to really protect our patients and ourselves. Are there any other lessons from this paper that you feel important for the therapist listening, watching? You did an excellent job, really. It was a pleasure participating.
Thank you.
And thank you again for joining us. And thanks for all who attended today's webinar.
I think we may have a new question here.
Oh, sorry. Okay. Was there a correlation between non-invasive ventilation and invasive ventilation with regards to fugitive aerosols if the filter was used on the respiratory limb of the circus? And that's from Scott Colombo, a great therapist.
So there was the one study I mentioned that looked at fugitive aerosols or aerosol dispersion with compared invasive mechanical ventilation with non-invasive ventilation. And in that study, invasive mechanical ventilation was found to produce less aerosol dispersion than other non-invasive procedures. The difference in that study compared to the one we discussed today is that evaluated air samples within the room. So it's hard to say without doing that extra step with this study to know how much dispersion we have going on within the room. But you would expect possibly that with mechanical ventilation or invasive mechanical ventilation, I'll say, it would be less since that had less dispersion in general. But you have to remember that other study that looked at high flow nasal cannula, the dispersion was low, but when you added the addition of nebulization, it increased the aerosol concentrations quite a bit.
Right. And what a wonderful, just for our audience and for myself, Denise speaks and addresses the questions and the content as a true researcher. This is a rare treat. I can hear in her discussions someone who's really, really thought deeply about this topic and about research in general. So it's really a special treat having her.
Well, thank
Any
you
other questions? Well, if not, we have to thank Denise again. She really brought the mindset of research right to the bedside today, and we have to thank her for that. These things take a lot of time to do, and she put a lot of time and care and effort into it. It was an excellent, excellent presentation and a real opportunity for learning that we can apply to the bedside. So we thank her. And we'd like everybody to please join us for the next webcast. It's on October 26th. Carl Miltram will present a lecture moderated by Kenny Harker on the new and updated PFT standards. So please, please, please sign in for that. And November 2022, Respiratory Care JournalCast, Maria Madden will be the presenter and the moderator, Tim Gilmore. And please, please turn in for that. And if you look at the slides, it will give you the directions for claiming credit.
Okay, we'd like to thank everyone for joining us today. We'd like to thank also to our speakers for sharing their excellent presentation. If you're a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. Once marked concluded, the system will automatically submit credit for you after you complete the survey. You can check your status in the credit submission tab. We hope you all have a wonderful afternoon.
Thank you again.